We'll discuss strategies for making sure your veneers and aesthetic dentistry last in this world of stress and bruxism and occlusal problems. See you there. Don't miss it.
La douleur péri- et post-opératoire? Asigam. Avec une triple action contre les inflammations des tissus mous. Action antalgique supérieure à celle du paracétamol. Action anti-inflammatoire rapide. Cmax obtenu en 1 heure. Action antipyrétique. Asigam.
Vous êtes à la recherche de la meilleure formation professionnelle en matière de santé? Des cours en ligne ou en présentiel, des ateliers pratiques, des conférences, des congrès, mais aussi des symposiums, des webinaires et bien plus encore. BK Med Events est la meilleure plateforme de connexion entre les professionnels de la santé et les acteurs de la formation continue. Sur la plateforme en ligne de BK Med Events, vous allez retrouver tout ce qu'il vous faut. Des prestataires du monde entier réunis en un seul endroit. Et si vous êtes des prestataires de la formation continue, nous avons une bonne nouvelle pour vous aussi. Juste restez focalisés sur votre programme scientifique et BK Med Events se charge du reste. De l'inscription des professionnels de la santé à la remise des attestations, en passant par une campagne de communication professionnelle pour mettre en valeur vos projets.
السلام عليكم ورحمة الله تعالى وبركاته ومرحبا بكم على قناة مجموعة التواصل لأطباء الأسنان للتعليم المستمر. Dear colleagues, welcome to our webinar today. It's a pleasure to have each and every one of you here. Whether you are a distinguished speaker or a valuable viewer joining us from around the world. To our esteemed speakers, thank you for sharing your expertise and knowledge with us today. Thank you once again to our speakers and viewers to being part of this event. Let's make this webinar truly enriching experience for all. The speakers at this webinar are Dr. Paolo Manzo and Mr. Emanuele Pauletto from Italy. The moderator is none other than the brilliant Moroccan Dr. Zuhair Abidin. Before giving the floor to the moderator, allow me to introduce him to you. Dr. Zuhair Abidin is a specialist in dentofacial orthopedics, master self-ligating brackets, diamond from Spain, European Master of Aligners from Spain, university degree in Scientific Medical Communication, University of Bordeaux, Ségalen, French, President of Moroccan Orthodontics Society, elected President of Mediterranean Orthodontic Integration Project, member of the European College of Orthodontics, member of the World Federation of Orthodontics, member of the American Association of Orthodontics, and author of several scientific articles and book chapters. The floor is now yours, Dr. Abidin. À vous.
Thank you. Thank you, Mr. Kamal Ben Mansour, the director of Tawassol Group, for this nice presentation. And it's very nice, and I'm very excited to be part of this great webinar. So, dear audience, welcome to this very special webinar of Group Tawassol. So the topic today is about bone screws, palatal, IZF, and buccal shelf in daily practice. So I will be your moderator for this session. Today we have the privilege of delving into a topic that holds an enormous importance in the field of orthodontics: bone screws, including palatal, intradontal free zone, and buccal shelf screws, play a crucial role in various orthodontic procedures, offering clinically valuable tools for achieving treatment goals effectively. So we are very excited because we have a lineup of speakers who will share their expertise today. So our first speaker will be Mr. Emanuele Pauletto. He is a dental technician specialist in orthodontics, and since 2015, he was a lecturer of the digital technologies at the Master Orthodontic degree of University of Insubria, and during the years 2018 and 2020, he was a visiting professor of the postgraduate school of orthodontics at the University of Ferrara. He is author of several publications in a peer-reviewed, very prestigious journals like European Journal of Clinical Orthodontics, Journal of Clinical Orthodontics, American Journal of Dentofacial Orthopedics, and Engel Orthodontics. And he is the inventor of MAPA, which is Mini Screws Assisted Palatal Applications Protocol, and he published several articles in this protocol, and he will share with us his insights about this topic. And our next presentation speaker, he will be my dear friend Paolo Manzo from Italy. He's a very smart and brilliant orthodontist. I have the chance to assist of some of his lectures. Very brilliant, and we will enjoy today this presentation. He is a doctor specialist in orthodontics from 2004 and a PhD in 2007. And he was a visiting professor in the University of Naples, Federico II, from 2008 to 2016. And he is currently a visiting professor of the University of Ferrara and University of Trieste. And he's a member of several boards, like the Italian Board of Orthodontics, the European Board of Orthodontics, and the European Board of Lingual Orthodontics from 2014, and the European Academy of Aesthetic Dentistry affiliate members from 2022. And he's a provisional member of the Angle Society, the Europe component, and he published a lot of journals, a lot of articles on the topics of lingual orthodontics, of digital orthodontics, and he's also the co-founder of the European Academy of Digital Dentistry. So I will give you the time, and we will enjoy your presentation today. So please, Emmanuel, go ahead and share your insight with us.
Thank you. Okay, you see my slide? Hello? You see my slide, my screen or not? Hello? Hello? Hello?
Hello?
Hello? Okay, now, okay. You see my screen now?
Just only you make a full screen presentation.
Okay,
We don't.
you
Yes.
see the presentation now? All right.
Yes.
Thank you.
Yes.
Thank you.
Good.
Thank you for
You're welcome.
presentation. Hello, nice to meet you. And it was a great pleasure for me and big honor to receive your invitation to do this webinar together, my best friend, my big friend, Dr. Paolo Manzo. And thank you for the invitation to Tawassol organization. Thank you also to the people who are connected with this webinar today. I'm sorry, but I don't speak English very well, and to be able to make you understand better, I read the same notes. I'm sorry. These are the topics we will talk today. We will talk about the evolution of the MAPA protocol. The MAPA protocol is the precision technique for palatal mini-screw insertion and for skeletal anchorage management. I speak in the first part of this presentation, and then Dr. Paolo Manzo speak about the new type of palatal expander for adult patient called tandem expander. And for the latest topic is the infra-bone steel. What is the infra-bone steel? Is a new protocol for digital planing and digital guide and mini-screw insertion in the buccal shelf area, infra-zygomatic area. I am from Vicenza. Vicenza is a little city in the north of Italy, near Venice. And Vicenza is a very famous city because it's the city of Andrea Palladio. Andrea Palladio is one of the most important architects in the history. And Vicenza is UNESCO World Heritage Site. And here they are the most important monuments of Palladio, like La Rotonda, this you see now, like the Olympic Theater, famous in the world because it's very famous for the particular acoustic and because it's made completely with wood. And if you come in Vicenza, you are very welcome. I talk about skeletal anchorage that is considered made by many orthodontists the most important innovation in recent years. You can see how also in this survey it is considered one of the most important innovations in the last years. Today, orthodontists can choose from a very wide range of mini screws. Some of these designed specifically for application in the palatal vault. There is a vast literature regarding the indication of the use of minuscule, which is not only used for orthodontics, for orthodontic purpose, but also for orthopedic purpose. These are the most commonly used sites where minuscule can be inserted, either directly by the hand or by planing and the guide procedure. For example, the zygomatic ridge, like this, or for example, the mandibular symphysis. The mandibular symphysis is also being used as an anchor site, and we can, with our protocol, planing and guide the insertion minuscule also in the symphysis, in the mandibular symphysis. Then the tuber, for example, is another site. Retromolar area also is another site, or interradicular. Sometimes is necessary to put the minuscule interradicular space, and we can, you can see in this image, we can plane in the minuscule even in a very difficult case like this. You see here, for example, the palatal minuscule. We can choose the palatal site, we can design the guide, and we can try the minuscule insertion, the direction and the space before they made the guide. But today, the widely used site is the Palat, which has been proposed by Kanomi as an ideal site. This is the infra-bone steel protocol, for example, for minuscule insertion in the interradicular area and incisor area. I will talk about palatal skeletal anchorage combining with digital technology. Today, in Italy, digital technology, in Europe, digital technology used a lot to manufacture the skeletal appliance, and digital technology is a possibility, it's not mandatory, and is not always necessary, and sometimes it's not convenient to make the appliance with digital technology, depending from point of view, different point of view. Today, there is a great interest in the Palatal approach, and in Italy, there are already many orthodontists who have introduced this procedure into their clinical practice. Here we can see some example of devices combined with the palatal skeletal anchorage, but we will see other later. These are authors who consider palatal tats irreplaceable in clinical practice, and this is because, as you can see, tats can be combined with almost all the devices that are normally applied to the palate. And the question is, why the palatal vault? The palatal vault, because the minuscule placed in the palate normally not interfering with the teeth movement. And the palate is the ideal insertion site for minuscule placement or for adult and young patients. Today, these are no concept, and we owe Kanomi for having changed the use of TAD that was made until that time. Why the palate? As reported by Kanomi and others, the reasons are anatomical, like low risk of root damaging, easy access. Normally, there is a good quality, a quantity of bone, and the soft normally the soft tissue is favorable. And but another important reason is the palatal minuscule have a low failure rate. But as we know, and as you orthodontists see every day, the palate does not always have an ideal width. And many of the patients who come to your office have a narrow and sometimes very narrow palate. So, in a palate like this, you see that there is nothing ideal. The palate is narrow, the access difficult, the mucosa thin, and the bone is rare. And these are cases where, to be successful, you need to plan the insertion of the TADs and the design of the device. In this year, the MAPA protocol has changed and improved a lot thanks to digital technologies. And in cases like this, digital technology is essential. We can see the position of the mini screws on the expansion screws, but also we can simulate the insertion to understand if the space is sufficient or not. You see another very difficult case. There is case where the insertion has been planning and where you see that the design of the template is also complicated. But in addition to anatomical indication that we have seen, there are also many biomechanical indications that we can read here. But palatal TADs, in addition to the orthodontic purpose, can also be used for orthopedic purpose. And this has opened new treatment possibility. And as my friend Bjorn Ludwig say, the Palatal offers an unlimited possibility of application. And about Bjorn Ludwig, who is considered one of the leading international experts in skeletal anchorage, I am proud of these quotes. Bjorn writes, I acquired my knowledge of 3D guide insertion from Emanuele Paoletto. And this is a very, very honor for me, this affirmation. Today in Italy, palatal approach is very actual and allows many orthodontists to integrate skeletal anchorage in daily orthodontic practice. And the hybrid expander that you can see in this video is one of the frequent applications, or the most frequent application. How to apply the mini screws? Some authors have suggested that anatomical reference for mini screw insertion. For example, Ludwig has proposed position and inclination guideline taking as reference the third Ruger. Winsauer instead says that the ideal point for mini screw insertion is the M4 site. As a reference, he takes a line between the two first premolars and calls this point M4 site. And then Professor Wilmes from Germany has identified this in the T-zone. The T-zone is the area where there is a great quantity of bone. Mini screw can also be inserted by a direct method, without planning and without a guide, as you can see in this video of my friend. As you can see in this video of my friend Dr. Antonio Darcier, whom I thanks. But today, however, even the authors we quote prefer a guide system. And this because sometimes non-guide insertion can lead to errors, which we see here. And errors and complications which have also been reported in literature. We have seen the anatomic guideline, and now we look at the anatomic limits. The anatomic limits that the orthodontist cannot violate during the minuscule insertion. For example, the incisor apex, or the anterior palatal foramen, or blocking or erupting teeth, the nasal fossa and the maxillary sinus. So the position site is sometimes an issue because the palate is not standard and vary. In fact, many other authors have said that the anatomic references are not always safe. And this because there is a great anatomical variability. And this variability does not interest only the bone thickness, but also the thickness of the soft tissue and the apex of teeth position. Sometimes we see cases like this. I started working on skeletal anchorage about 30 years ago, and this device from those years, which were anchored to osseointegrate implant, the concept, the concept of the TADS is different, but the applying is the same. The biomechanics is the same. From the beginning, our system was aimed to the patient protection and the dentist safety. And we developed a system for guided implantation called MAPA. And in 2004, we published this first article in Italy. In those years, there were no digital means, and the work is very, very long and very, very difficult, and sometimes not precise. However, orthodontists have changed, and today digital technologies can help us a lot in the design as well the construction of the device. We can see how the first publication relating the possibility of the preparing orthodontic appliance are almost 20 years ago by Nur al-Mortadi, for example. In more recent time, Dr. Simon Graf has introduced many innovations in this field. Which approach to use about lab construction? We can use digital, analogic, or mixed approach. Today, orthodontists can use skeletal anchorage in very different malocclusion. Here you see some device built with 3D technology, other built with orthodontic wire, traditional orthodontic appliance, and other with a combined system. But this choice, in my opinion, also depends on personal experience. I want to go back in the years. These are devices made 20 years ago, and I don't find them less charming than those we have seen before. For the clinician, the important thing is that the device working well, and the method by which they are built is less important. It is more important to know the biomechanics and how they have to be built than the process used to be built. These are other devices built with digital protocol, and you can see different kind of device, intruder, part intruder, distalizer, you can see anchorage bar for intrusion, very different design, normally inserted in the two meniscus placed in the paramedian area. A lot different design. You can see the pendulum appliance, the pendulum combined with the expander, with the hybrid expander. We see in the center an appliance we call SCAR3, is a hybrid expander for class 3 malocclusion. Very different design. And finally, we can see this new type of design. We combine different system for example, for distalization. We combine the hybrid palatal expander to distalizer system, to distal slider, and with the new approach is called DMD, is a new approach for direct anchorage for molar, simultaneous molar distalization. The first and the second molar distalization is called DMD, a new type of the device. These are the orthodontic area where the digital technology are used. Today, very often images are acquired with digital procedure. Important changes due to the introduction of the new record acquisition system like such as digital impression and CBCT. Also, image processing system today allow the planning for the forecasting of the result of the treatment with high precision. In this way, we can process the image, plan the treatment, and design the device to be used. And the last step of the digital process is the transformation. The transformation process allows the passage from virtual to real with additive manufacturing system technologies. In the digital age, this represented three important innovations: planning, design, and construction. Now we'll see some steps of the meniscus planning with the MAPA protocol. We revised our protocol, and with the digital technologies in 2015 and 2016, we published in the European Journal first, and then in the Journal Clinical Orthodontics, the first digital protocol for meniscus insertion. We combined our MAPA system with 3D technology, and with the use of CBCT, of FSTL file of the meniscus, and the 3D digital printing, we can apply the meniscus in the palate in very reliable way. MAPA is a precision technique of which goals are simplify the clinical procedure, overcome the anatomic variability, and then enhance the success rate. And the most important, the safety insertion. The most important safety insertion for the patient and for the clinician. And finally, we have seen during the year, the MAPA protocol can open the new treatment strategies. This is our goal. This is our goal using digital file to plan position and inclination of the meniscus to allow the bicortical anchorage, which is a key factor of stability. We can see exactly the bone, the soft tissue thickness, and the incisor apex. Today, the protocol has evolved thanks to artificial intelligence and the new segmentation method. These are the main decisions we take when we plan the meniscus insertion: where, how deep, which inclination we insert the meniscus, Today, it is possible to individualize the insertion of miniscule adopting a planning method. With planning, we must take into account not only the position, but also the depth and inclination. Where insert? Where insert depends on the anatomy, depend of the patient age, depend of the device type that will be used, and then depend of the root position. Here you can see solution with 2, 3, and 4 mini screw in anterior and posterior part of the palate, in right and the left side. In this three-dimensional video, you can see how the point of the insertion is the same, but if you vary the inclination of the length of the miniscule, the length of miniscule change. And our goal is to use the longest miniscule possible to reach the deep cortical. And in posterior area, in order to use the maximum amount of bone, the inclination is even more important. Here you can see how important is the inclination in the posterior area. Only with a correct inclination, we can achieve the tricortical anchorage, which is a new concept introduced by the MAPA protocol. In this image, we can see the expansion produced by the appliance, but above all, we can see the miniscule engaging the sinus and nasal floor cortical. And this is called tricortical anchorage. And I want to thank Dr. Angela Arreghini for these images. And I am also proud of this article published in 2018 and the fact that American Journal Orthopedic or Orthodontic dedicate a cover to my planning. With a little pride, I show you this recent review of literature where the MAPA protocol was considered at the first published protocol for miniscule planning. Here I am with 3 stars, Professor Manzo, Professor Moon, and Professor Arnett, my big 3 friends. I'm sorry, but we don't have time today to explain how the protocol is highly evolved today. And here you see an example for how 3D segmentation and reconstruction and here you see an example of how 3D segmentation and reconstruction can help us in planning the miniscule insertion and in device design. In device design, and in addition to the device design, the new technology help to design, allow to us to produce the template with very different design, different cases. And this is the video. You can see the step of miniscule insertion, the guide, the cylinder guide, the resin cylinder guide. We insert the 2 sleeve for have a great precision system, and then sometimes the doctor prefer to pre-drill the miniscule site, and finally the miniscule insertion with the high level control of the tooth inclination, of the miniscule inclination and the tooth height and position. And I think that the orthodontic area where digital technology has opened new important opportunity is the skeletal anchorage. And for this purpose and with pleasure, I present to you this book published by Professor Nanda 2 years ago with our MAPA article. And in the introduction, Professor Nanda writes, a very interesting development in skeletal anchorage present in this edition is the integration of the three-dimensional technologies for the placement of minuscule implant and then the fabrication of the TAD supported appliance. And the MAPA protocol facilitates the insertion of mini implant and then delivery of the appliance in single visit in very precise and predictable manner. I'm sorry, but today we don't have time to tell you about the one visit protocol that was published in 2017 and got us another cover on a JCO. I finish my presentation with these images. I thank you for your participation. And now the second part is presented by Professor Paolo Manzo. Thank you.
Thanks for all. So you have a chance to put it right, by the way.
Okay. Thank you, Emanuele. Please, I ask the friends from Tawassol if they can give me a feedback that everything like audio is okay. I don't hear you.
The audio is okay, Manzo.
Okay, let me check if all the sharing is okay.
Okay.
Good. Yeah, you see my screen? Yeah. Okay.
Yes.
Thank you. And hello, anyone. Thank you for being here. And thank you also to Abidin, Dr. Abidin. Thank you very much for your nice introduction and your sharing this session. This is a very smart group from my friend Rashid. I love you. We are very good friend, very close friend, and I think we like to share our experiences, our knowledge. So everyone is very involved in this, and I think you are one of the best group in the world. So I'm very happy to be here today with you. And following the presentation from Emanuele, I want to present now the clinical part of something connected with our work. As Emanuele told you, we work a lot with digital planning of the introduction of the screws in the palatal bolt and also in the infrazygomatic crest and buccal shelf. Today the time is not so wide, but we will have a chance to share some aspects of our work. And I want to present you Viviana. And Viviana, she's 29. As you can see from the profile, Viviana's profile is also sublining a kind of hyperdivergency that is very, very severe. She has a slightly convex profile, a lot of contraction of the lips, of the muscles, and here in this adult patient, we have also a very severe crossbite on the left side, and we have a crossbite even if the lower arch is very contracted. Also, Viviana, she was extracted before to come to my clinic of about 3 first molars. So she has only one remaining first molar. And when you look at situation like this with a lot of space to manage, you can see how much the only existing first molar in this arch is so wide with very big roots. My endodontist, she was very scared about this. She told me, Paolo, tell the patient never to take care about 3.6 because if we need a root therapy, we need very long instruments here. And this is the divergency with a very severe hyperdivergent pattern, and also the very severe gummy smile from this patient. And this gummy smile, from the classification published by Goldstein in 2009, is due to 2 kinds of problems. The first problem is the hypermobility of the upper lip. So she, when she smiles, she really expose a lot of the gingiva, also for this lip that is hypermobile. And also we have a vertical maxillary excess with a short ramus and a clockwise growth of the mandible. Now, in a patient like this, one of the most wise thing to plan, to schedule as an ideal treatment plan is a surgical plan with maxillary impaction and expansion and the mandibular advancement, then to take care also about genioplasty. There is a reduction in the vertical side and improvement in the sagittal side. But as usually it happens in patients like this, they ask us they are looking for a kind of treatment plan that is not a surgical one. They want to improve the smile, they want to improve a lot of aspects of the social life, and they ask me and they ask us if we can do something. And in a patient like this, with hyperdivergent pattern, crossbite, she lost 3 first molars and also altered passive eruption. So an excess of gingival and also bony tissue, so an excess of superficial and also deep periodontal tissues that are covering the roots. Probably we can do a lot. So we planned, first of all, the correction of the crossbite and the expansion of the upper arch by means of the bone-borne expansion. Then we planned a full fixed appliance for the space closure and for the settling of the occlusion, and a periodontal surgical treatment of the altered passive eruption with a reduction of the bone and also the gingival tissue covering too much the teeth. And finally, we planned, because we discussed it also with the patient that usually after perio-surgical treatment, and also because she had a Bolton, so dental sides anterior discrepancy, we should need aesthetic direct restoration or indirect, it depends. So some aesthetic restorations in the anterior, at least the upper teeth. And we planned, me and Emanuele, to place 4 screws, 2 in the posterior areas and 2 in the anterior areas. And these screws, they were planned with the digital planning made by Orthomodul, by Emanuele. And usually what we do is to start from a kind of digital planning. Then I review this with my coworkers. We approve or we modify. And to be honest, it's not so frequent to modify something. It's very rare that we ask some modification, because usually Emanuele, he works in the tendency of doing something very, very close to the reality, so something very reliable. And we planned also 2 screws in the back. So 4 screws totally. And for the screws, sometimes when we have a chance with Emanuele, we try to have a 3 cortical kind of contact point. So in this case, with the 15 millimeters screws, we can engage the palatal cortical tissue and also the nasal cortical tissue and also the sinusal cortical tissue. And this is the virtualization with the digital planning of the 4 screws. And this is the way we receive two templates. In a case like this, they are very close, so we need the two templates, one for the anterior and posterior, and another one for the other anterior and posterior screws to place. And then I place it with a clinical session that usually is no longer than half an hour, 45 minutes, 4 screws, and if possible, if it's a one visit approach, we can place the appliance, so the expander, in the same session. Or if it's not a one visit approach, we can take a kind of a very precise impression with the polyvinyl siloxane or with the scanning. Usually we use a intraoral scan, and Emanuele can produce for us a kind of expander. In this case, with Viviana, we used a tandem. Why did we use a tandem to open this suture? And you can see how much we opened this suture in a parallel way on the anterior area and also on the posterior sutures. That is even more important, because we know that to open the anterior suture is very important, but the most important and critical area is the posterior area, with the connection between pterygomaxillary suture and all the posterior sutures that are quite more complex to open. In this patient, we used the tandem because the tandem appliance is made with 2 screws, one on the anterior and one on the posterior. So we can ask the patient to activate symmetrically or asymmetrically, so in a synchronized way or asynchronized way, the anterior and posterior screw. And in most of these patients, we usually have the opening of the suture that is a symmetrical opening. And this is the opening of the suture of the palatal vault with Viviana. We opened the suture. We can go on with the correction of the crossbite. And this is Viviana. Once we opened the suture, now we have to treat the patient for the orthodontic issues and also to solve after orthodontics for this periodontal problem. So we opened the suture, we treated the crossbite, and now we are able and we are ready to start with the orthodontic treatment. And during the orthodontic treatment, we don't need skeletal anchorage anymore. With the straight wire classical techniques, we can keep the anchorage and we can close these tremendous, very big spaces. And once we arrive at the desired expansion, for example, here in the posterior screw, we block it before then the anterior. And now we have quite completed the space closure on at the upper arch and at the lower arch. This is the closure of the space. We disengaged the appliance also because usually after the opening of the suture, we observe a period for the stabilization of the bone, so stabilization of the opening of the sutures. But then, as we are ready to do this, we try to remove the appliance because the tandem appliance is quite more big to adapt. The patient needs more time. So as we have a chance to remove it, we can cut it or we can remove it. Usually, if we cut the anterior part, the patient has a lot of comfort more. When it's possible, after a total period of time of 6-7 months since we started with the expansion pathway, we can remove full the appliance. And with this patient, we completed the orthodontic treatment, and now we can start with the perio surgery. Perio surgery that in a lot of our patients we do with a guided surgery, so CAD/CAM printed surgical guides, and my periodontist, she made a surgery of this girl with reduction of the bone, reduction of the gingival tissue, so superficial and deep periodontal tissues. And this is after 1 month after surgery. And now we can start with the restorations. In this case, as the patient was very young, as the patient would to be also able to modify something in the next future or to move to indirect restorations, we started with direct restorations. And my specialist on the direct, he made a kind of evaluation a kind of walks-up, so on the cast, then a mock-up. There is a trial, is a very primitive trial in the mouth. If the patient says, okay, doctor, I'm okay with this restoration, we can go on with restorations. And once we finish, the kind of outcome is something like this. And when we finish it with this work, now Viviana, she changed it completely after the finishing phase, after expansion, after the surgery, and after the restorations. And this is the sequence of the treatment at the upper and the lower arch, also with the space closure, and with a bonded retainer that I use in 100% of my patients at the lower arch. In the meanwhile, at the upper arch, in my patients, I use removable plates or I use a combo. So removable plus bonded retainer. And this is the sequence of the treatment of Viviana. This is the sequence, this is the orthopanoramic view of the closure of the space. It is a good closure of the space with also good calibration of the movement of the root, so very bodily movement. We are very satisfied about this. And this is Viviana at the end, no surgery, a kind of camouflage treatment, but she improved, as she asked us, she improved from the aesthetic point of view, from the functional point of view, and we corrected the gummisma, crossbite, we closed the space, so no implants, no prosto rehabilitation, and only direct restoration on the upper teeth. And this is Viviana. We didn't change with surgery or with any kind of treatment the hyperdivergent pattern of this patient, but we can feel very comfortable about what we changed about the aesthetics and the function of the anterior. I want also to tell you that me and Emanuele with Manzo Academy during in my office connected clinical course room, so classroom, we are going to provide a kind of course on the digital planning and guided insertion of the screws. That will be November 2024. If you want to join us, you are more than welcome. You can send an email to this email address or direct it or contact to me, or you can contact our friends from Tawassol. I want to show you also the QR code of the social Instagram and Facebook of the Manzo Academy, because usually we share our experience. We try to make some quits, some kind of stories. Sometimes we publish some clinical reports or some scientific reports. So we will be very happy to join to make you joining our group. And going on, I want to show you also Giuseppe. He was 36, and as you can see here, a very severe crossbite from all the left side of the arch. We have a full cusp crossbite from the lateral incisor here. This is another very complex patient with a hyperdivergent pattern. And anytime we have to correct a crossbite in a patient of this, like this, we need a kind of expansion that is very controlled. We need to avoid extrusion of the molar, extrusion of the palatal cusp. We cannot do only dental expansion. This is a adult patient. Probably what I say to the patient, we try to avoid the surgical intervention, and we are working until 40, 45, no more years, but a lot of these patients we are able to expand without the surgical session. And this is a very severe crossbite with a lot of decalcification connected with this this enamel destruction. And we planned here 4 screws again, 15 millimeters and 16 millimeters anterior and posterior, again with a tricortical approach, like you can see on the right image. Again, planning a tandem solution, so 1 screw in the front and 1 screw for the expansion also in the back. And I want to show you also how did I monitor with artificial intelligence and remote monitoring the progress of the treatment of Giuseppe, because we have a chance with remote monitoring, and I work a lot with artificial intelligence. We have the chance to monitor this kind of patient since the time 0 until the big opening of the suture, until big expansion of the palatal vault. And you can see how the artificial intelligence for us And if we want, we can share also with the patient, but if we don't want, we can avoid to share. But this is very brainstorming, because we can catch exactly by the reconstruction made by artificial intelligence of the frames, how much the expansion and the correction of crossbite is happening. And this is the opening of the suture of Giuseppe. There is a very wide opening. Sometimes we have not this kind of result even with the surgery. Okay, and we can check how much we open it in the front, how much we open it in the posterior area, and this is superimposition made by Emanuele, how much we open it, because we can measure for the bone-borne expanders. So for the appliances, they are only on the bone. If we measure the expansion on the teeth, these are no touching teeth appliances. So we are measuring actually the skeletal result. And after we transformed a complex case now in an easy case, in a more easy case, and now we can treat with a fixed appliance, with aligners, whenever you want. So we can treat with aligners this case, and finally to have this kind of result. This kind of result. Then Giuseppe, he was very happy about the result. He didn't want to make a direct or indirect restorations to any kind of tooth. No restorations on the molar, and also we proposed this patient to make some periodontal surgery again, because he has a altered passive eruption as well. But he was very happy about this result. He said, "Okay, doctor, I'm okay." Also, he had a very good outcome, not only from the functional, not only from the aesthetic point of view, but also the numbers. These are provided from the artificial intelligence. We know exactly that we expanded around 8 millimeters on the molars, okay? And this expansion made us reducing the snoring index. This boy was very, very, very impressed and affected by the snoring. He told me, "Doctor, I cannot keep any kind of girlfriend close to me because I have snoring so high." He has 92% of snoring, and in the acute phase, not chronic phase, but soon after the treatment, the snoring index was reduced at 7%. And I think we can provide this kind of result as a very good result also for our patient. I published it together with my university, Federico II, many years ago, how much we can expand with maxillary expansion. This paper was published on International Journal of Pediatric Otolaryngology, and we demonstrated that the 3D with low dosage CT scans, a 3D expansion of the nasal cavities. With this, I don't say to the patients that if we expand the maxilla, for sure they will be alleviated from the snoring, from the respiration problem, from the OSAs, obstructive sleep apneas. But we can tell them that the science and the reports, they demonstrated us that we can open in a reliable and also statistically significant way the nasal airways. Only to show you that Giuseppe, that was monitored with artificial intelligence, compared with this girl, Viviana, he came in my office only 3 times. And Viviana, she had to come 14 times compared with Giuseppe. So a very big increasing of the efficiency. But today we have no chance, no time to discuss about this, but it's nice to tell you that we presented also, me and Emanuele, and also the School of Ferrara. I'm proud to teach at Ferrara University as visiting professor. We presented our work also at the Harvard University as interdisciplinary work and also as artificial intelligence-based work. If you want to go deeper, I prepared for you this QR code. You can take a shot of this, and you can go deeper in this argument, because you can find some articles, some tutorials, something in the area of the Manzo Academy that you can go in and go deeper in this kind of topic and issue. Also, to show you only a sequence of treatment of this 30 years old girl, she's 30. opening the suture again, a lot of expansion of the upper maxilla with 4 screws and with the tandem again. And this opening of the suture was absolutely huge, very big, with no touching appliance again, so tandem that Emanuele demonstrated you. And again, artificial intelligence telling us that the patient is improving. So from the scans, the patient has only to work with a smartphone. And this is the frame reconstructed by artificial intelligence of what is happening. So if we want to share with the patient, we can also brainstorm the patient during the treatment. And this is Viviana. Now we can start with the fixed appliance or with aligners treatment and to correct the class 3 and to go on. But a very interesting point is also that for me and in my experience, artificial intelligence is very important also to provide me a lot of data relative to the expansion. Sorry. For example, here you can see that we expanded the upper left first molar 3 millimeters each side. And also it's important for me to know that this black line that represents the mandible had a spontaneous, consensual, without any appliance expansion of 0.7 millimeters. So for me, it's very important to have this kind of data. This is analytic data that I can be provided of by the artificial intelligence. This is one of the reasons me, Emanuele, and my co-workers, we are working a lot with artificial intelligence and remote monitoring. And again, with artificial intelligence, we don't have to scan, we don't have to measure, and we are working to a kind of set of data that in few months will be available for everyone, that we can measure more than 11 millimeters of expansion at the upper arch. And this is very important for me. Also, we published this in a white paper for the monitoring of the patient, especially adult patient, and you can see the evolution of the monitoring in a patient like this with the crossbite, again, correction of the crossbite, then we can move. If you see, like Dr. Abidin, also we like self-ligation, and also we can monitor younger patient, adult patient like this, okay, with the expansion, correction of the crossbite. And now I want to move to the last slides of my presentation to present you the work we are doing as a skeletal anchorage on the infrazygomatic and buccal shelf crest. First of all, I want to tell you that infrazygomatic crest is a very, very important area for us because we can correct the class 2 being outside of the root from buccal side, so without potentially effects on the rotation of the molar, so in a very efficient way. Also, Chris Chang demonstrated us with a paper published in American Journal of Orthodontics 2022 that the reliability and the survival of bone screws is 95%, so is higher compared with the interradicular implants is 80%. And with infrazygomatic screw, we can make a maxillary arch distalization, so we can treat class 2, or by protruded patients. We can also make a molar intrusion. We can also disimpact from the buccal side, the buccal impacted canines that you know are quite more complex sometimes of the palatally impacted. And we decided together with University of Ferrara to assess and to check the accuracy of the bone screws positioning of the infrazygomatic crest screws by means of the guide. And I presented this work to the Angle Society of Europe 2 years ago, and now we are going to be publishing the next month probably about this kind of research that we implanted the 17 screws in this pilot study made in my office with these 11 subjects, and we checked the reliability of the positioning of the screw in the infrazygomatic crest. We presented also together with Emanuele, with some of my co-workers and with the School of Ferrara, this kind of work at the Chicago American Association of Orthodontics Conference 2023. And the procedure is based on the digital planning on CBCT scan and on intraoral scan, the digital planning of the screw positioning in order to check the best available placement in the infrazygomatic crest. One point that I want to point out very clearly is that, in my opinion, and also Emanuele's opinion, is even more important to plan the screws in the infrazygomatic crest than in the palatal vault, because in the infrazygomatic crest, we need to know exactly what kind of bone to touch and how much the depth of the screw should be, because we have to know if to go in the sinusal area, in the Schneiderian membrane, because we know that if we can penetrate the Schneiderian membrane until 2 millimeters is okay. But if we don't know where to place the screw or how much we go inside the sinus and how much we invade the membrane, probably this is a big problem. And also, if you follow the Chang positioning technique, before horizontal, then vertical, yes, you can place the screw, but most of the time you are very close to the roots. And also, Chris Chang, in this paper of 2022 on American Journal, demonstrated that at least 7% of these screws, they have to be replaced during the movements. And I don't want this. I want to make only one intervention in the best available bone for the patient, to take most of the bone available in only one time, surgical time, and I don't want to remove it, because this screw can be very reliable. And this is the planning, so the procedure that Emanuele makes for us. We can place the screw manually, or we can place the screw with a motor, so guided surgical like a conventional implant. And once we approve the digital positioning, Emanuele can print for us a printed guide that is usually covering all the upper arch. It doesn't matter if you place a screw only on one side or to both sides, but we need a full arch covering like this. And we have a kind of cylinder guide to be very precise with the zygomatic extension, to be very precise in the positioning. And this is a kind of printed guide on the stereolithographic model. And this is the printed guide in the mouth of the patient. And I want to show you also a kind of intervention. In this case, we are placing an orthobone screw, 12 millimeters height, and is a manual positioning. As you can see, I'm going deeper and deeper in the infrazygomatic crest with a planned positioning of the screw. And once the reference guide is touching the reference on the printed guide, I can remove the screwdriver, I can remove the printed guide, and I place the two screws, and we are ready to start with a fixed appliance or a liner treatment as you choose. And this is a kind of placement, as you can see, is a customized placement, so can be different from left side, right side on the same patient. It doesn't matter, because we choose with a guided insertion, we choose the best available place, the best available position regarding to the bone, regarding to the sinus, okay? And we can combine with some biomechanics, with the power arms, we can combine with aligners. We then can check if the digitally planned position is reliable with the real surgical guided final position. Then we use it with University of Ferrara to check with the superimposition. We measured how much was the difference between the planned and the real positioning, and we found that on the tip we are precise, more precise than 1 millimeter. So the standard error is less than 1 millimeter on the tip and less than half millimeter. So it's 0.37 on the cap. Okay. And for this, it means that also now we are working on the Buccal shelf screws. And if we compare our results with the only paper published in the literature from Chinese, they measured the accuracy with 3 kinds of guides compared with the most precise guide, we had from this paper more than 1 millimeter as accuracy. We are more precise than this. So these are our preliminary study data. Then the application, they are a lot. We can attach directly to the bracket, or we can attach to with a core spring or with a power chain directly to a power arm, okay, like this, with aligners, with a bonded appliance, so with a fixed appliance. We can use in a class 2, we can use in a bi-protruded patients by combining with the Buccal shelf that is also guided in our infra-bone protocol that we publish it, and we can combine with a lot of biomechanics is depending by us. Our perspective, we are working with a body scanner in order to put the body scanner on the screws and to take intraoral scan and to check the accuracy and the positioning, not anymore with another combi, but only by means of the scan, intraoral scan. So in this way, we can cancel one combi for our patient, and we can arrive at the conclusion that this method is predictable. As the infrazygomatic and Buccal shelf positioning of the screws is quite unpredictable for the height of the bone, the thickness of the bone, the width of the sinus, and also very large inter-individual variability. We have a lot of variability more than Asian people, okay? It means that there are possible interference that we don't like, so we like to plan the positioning in this area. So the guided infrazygomatic crest implantation is increasing the predictability of the TED's positioning in these areas. And also, we are very happy to announce that only a few days ago, we published our paper on a observational study on the journal APOS. Now is available online, then will be printed in the next days. And I want to finish with showing you some applications of the screws with our screws. We are testing a prototype of the screw until 16 millimeters of height, of length, because we think that actually most of the time we need a screw that should be 14 or 16, no less. So 12 probably for a lot of patients is too short. These are kind of patients with the skeletal class 1. And when we have a skeletal class 1 and we have increased overjet, sometimes we have a crossbite. Before we can correct the crossbite, then we can start with our screw positioning in the infrazygomatic crest, customized positioning, digital planned positioning. And I'm working also with the no compliance sagittal first. So we don't need elastics for the patient. They don't have to comply, and they don't have to collaborate with the elastics. We can control. These are scans from the artificial intelligence and remote monitoring. And we are working in this way by improving the class relationship with a no compliance system. We can measure also the amount of force, and also we have in the literature a clear demonstration that if we can work both with the short and also with normal carrier motion appliance or sagittal first appliance, doesn't change because the result is quite the same. Only we have to extend a little bit the timing of the treatment. This is a class 2 of one patient. We treated in this way, I showed you, and with power arm, with no compliance, sagittal first approach, again, with more controlled force that is closer to the center of resistance. Then we can improve with two coil the force, because any side we have to arrive to 250 grams of tension, and we can improve. Remember that anytime we use infrazygomatic screw, the line of action of the force has a tendency to the buccal area, so we are expanding the canines, and this is very easy to control. But overexpanded canines like this, sometimes we only need some power chain, and after a couple of appointments we can go back to this kind of unwanted effect. Sometimes when the patient is also not collaborating like this, she's a girl with a static carrier motion or power bar. Now I'm working with power bar from American Orthodontics. She didn't work at all for 5 months, and the result was quite the same after 5 months. Then we decided also to work from the infrazygomatic area, but me and Emanuele, we checked that there is no bone. And sometimes we have to have an alternative from this side. So now we developed a DMD, a kind of appliance that is palatally supported, but with a arm that goes buccally. We can provide a kind of force directly here to the molar with a coil spring, and we can correct class 2 from the buccal side, but with palatal screws. So palatal screws, but buccal side correction that from our point of view is much more efficient and effective. I want to thank you for this, for your attention, and I'm very happy to be with you, to have been with you today. Thank you very much.
So, thank you very much, dear Emanuele and Paolo, for this outstanding lecture. It was very interesting. So you show us how digital planning allowed us to overcome individual variabilities, how to overcome some complexity in the mini implants insertion. So it was very outstanding. Thank you for this presentation. So I don't know if there is some questions. I have some questions, and we will open, if you want, the Q&I session.
Yeah, I can answer to this. Emanuele, if you allow me, I should answer to this, because we usually we prefer screws over the plates for 2 reasons. First of all, plates are more complex to be placed, and in my office, I don't know you, but in my office we need the surgeon, and I have a surgeon, but I prefer to place a skeletal anchorage by myself. Yes. And so it's faster, it's easier, I can do by myself, is reliable, and also we can do guided surgery with the screws, not with plates, and also is cheaper and faster also for the patient, not only for us.
Yes.
Thank you for this question.
Yes, I agree with you. About the tandem, I have a question about the tandem. So the activation of the 2 expander screws, is it the same activation? And how much millimeters per day you recommend?
Actually, now I try to answer, but also Emanuele, if you want to add something. From my point of view, actually, our tendency all over the world is to expand very slowly. So it's not to expand too much. So we till some time ago, we provide the patient a kind of prescription to expand with 1 activation, anterior and posterior. Then you depend how much you have to expand, but 1 anterior, 1 posterior every 2 days. Now we are moving to 1 activation every 3-4 days, even less. So a very slow protocol.
So one activation is 0.25 millimeters?
Yeah, exactly, yeah.
Okay. So it's very slow.
Very slow, yeah.
Okay. There is another question from our audience.
Yeah, can you discuss any recent innovations or the development in Moscow's technology that have enhanced their effectiveness or the ease of using clinic? From my point of view, I don't know, Emanuele, but I think that the softwares with artificial intelligence, they are able to combine intraoral scan, COM-beam, and all the records, also facial scan, they make this very predictable and very fast. So for me, is the improvement of the imaging and the artificial intelligence. They improved a lot our techniques in daily practice then. Emanuele, do you agree with this? Yeah. How do factors such as patient age, skeletal morphology, and treatment goals influence the decision to incorporate? And okay, first of all, we should check the maturation of the suture, but also now is important also that the patient is not over 40, 45. We arrive usually at that age, no more. And also, if the patient is willing not to do surgery, because obviously surgery is the fastest thing, is the most reliable approach. But I believe that, Emanuele, in our experience, we have like 95% of success. So I can say this is in our experience. Then we have from literature also very interesting reports, but I can tell you that in the selection of the patient, the age and also the amount of expansion is important to be evaluated. But now most of the patients till 40, we are still treating it in this way if there are the clinical conditions, if the diagnosis is okay.
Yeah, very interesting. So I have a question. You in your presentation, Paolo, you spoke about the three cortical contacts. It's not enough the two cortical contacts for the anchorage?
Emanuele knows this very good because he invented this. And I want to tell you that when you have three cortex instead of two, is like you have not a motorbike, but you have a tandem. Okay, you have three wheels, so it's much more stable. And now Emanuele also demonstrated with some reports that there is a kind of stability increased, and there are some papers now that are going to be published in some research also from University of Ferrara, demonstrated that tricortical approach is for sure better than not always you can, but if you can, it's better.
So we have a predictable expansion and symmetrical one.
Yes, because you have the tip of the screw among two cortex, and the emerging part, so the occlusal part is in another cortex, so it's very blocked, no?
Yeah. Okay, we have another question from our audience.
Yeah, the stability and success. First of all, during the treatment, usually you see, because you see the result. If you see that the expander is moving, first of all, the patient says you that sometimes that he has a pain. So if you have inflammation, usually the patient tell you. Then sometimes you have the expander that is expanding and maxilla is not opening. So sometimes this most of the time it happens for this reason. No stability, no good stability of the screws. You can remove also the appliance and you can check, but sometimes you don't need this. because you have inflammation, you have coverage, and so something like this.
I use the MEC, the one moon expander, and when we don't have these bicortical contacts, I have sometimes an expansion, unilateral expansion, only one side, and the other side nothing happened. It's very very difficult to fix this issue. How do you think about it? How we can
Emanuele, do you want to answer to this? Because also we have some time.
Rispondi tu, una roba clinica.
Sometimes it happens also to us. The expansion most of the time is not very symmetrical one. It depends from how many kind of tensions you have on one side or the other side. To be very clear, most of the time, especially if you have only unilateral crossbite, you have more tension on one side. You can have opening of one side, and you have some difficulties in the correction of the crossbite, and on the other side you are going to scissor bite. No?
Yeah.
It happens.
We have another question from Rashid, our friend Rashid Abu Said.
Yeah. How do orthodontists collaborate with a surgeon and periodontists when incorporate bone screw into comprehensive? To be honest, I incorporate bone screws exactly to don't have to deal with the surgeons and periodontists, because I do a lot of interdisciplinary treatment and I discuss the treatments with them, with my team, periodontists, prosto, and this. But when we include the bone screws, apart from the cases we have to make also to manage some periodontal treatment before, prosto rehabilitation, intrusion, and this, usually we can manage also without a lot of implications in this.
Yes.
Emanuele, do you want to answer this?
Yes,
but now we use different software. For digital planing, we use Anatomage in vivo from Anatomage. Then we can use for digital planing, we can use a software, a CAD software is Rhinoceros. And now for minuscule insertion, I use the Italian software, is called Real Guide, but it's a software specific for implant planing, prosthetic implant planing. And we adapt the software with my necessity. But now we have a lot of software you can use. It's clear?
Yeah.
Yes. I have another question about the length of the screws in the infrazygomatic crest. Which length you recommend? Because we can use 12, 14. Which one you recommend?
Vuoi rispondere tu o Lele?
No,
the screw.
If you plane, you choose the mini screw adapt for your case.
Yes.
You see, this is the great advantages. And you can put the mini screw. We have a new type of mini screw with only short part with screw, and then is Paolo, forse meglio che lo dici tu in italiano.
And then we have a new prototype we are working on. It should be available in a couple of months. We are working on 3 sizes, 12, 14, 16. And most of the extension we use, the size is 16, because if 16. You plan it, you can really place in the best bone site. And we have a very small part going in the bone, because we have seen most of the patients, they don't have more than 4, 5, 6 and the maximum bone millimeters, but is enough. Even if the cantilever is very high, the bone is very, very, very hard, so is enough to be stable. And all the rest of the part of the screw is very round in order to be very compatible with soft tissues. So we are working with this.
And the great advantage is if you can put the head of the mini screw where you want for your point biomechanical necessity. You want to put short, long, etc.
Yeah.
Different level.
And in the mechanics, yes.
Yeah.
Well, it was very very interesting, and I don't know if there is some other questions from the audience. If not, so I would like to thank you very much for your insights and for sharing with us your knowledge. It was very interesting for me, and you really demonstrate how digitalization today and artificial intelligence can be very useful and helpful for our field.
Yeah.
And it will be something. It's our present, and the future is brighter. No.
Yeah. I like this. Thank you, Zahir, and thank you to Rashid. Thank you, Emanuele, and it was very nice to be together.
Thank you to all. Thank you. I'm sorry for my English.
Are you going to the AO meeting?
This year, not.
This year,
next year in Philadelphia, yes, but this year, not.
Okay.
So I hope to see you very soon. And a big kiss to all the friends from your group.
Okay, thank you.
Thank you.
And a big hug to your
Emanuele. Thank you, Paolo.
Thank you. Bye bye. See you. Ciao, Paolo. Thank you. Bye bye bye.